My name is Bram Roshberg. I'm an assistant professor in the Department of Medicine at McMaster University. My pleasure to give a brief synopsis on the treatment of pain, agitation, and delirium in the ICU. A lot of my suggestions around clinical practice will come from the most recent pain, agitation, delirium, immobility, and sleep guidelines that were published in 2018 from the Society of Critical Care Medicine and the European Society. The focus will really be on the domains of pain, agitation and sedation, and treatment and monitoring for delirium. Let's start with discussing pain. When it comes to pain, routine assessment by bedside nurses is crucial. It ensures we don't fall too far behind in terms of pain management, requiring extra doses of medications to play catch up. And this usually entails some sort of opioid-based analgesia. My preference in intensive care patients usually to use agents with slightly longer action like hydromorphone and avoiding short-acting agents like fentanyl or infusions if at all possible. There are certainly exceptions to this case, patients with exceptional pain requirements or those that are heavily sedated, perhaps those requiring high levels of ventilatory support. We'll talk a little bit more about pain shortly, but let's combine this conversation as well with sedation, given that they're so closely linked. Our suggestion in critically ill patients is to use an analgesia-first approach. What this means is treating pain prior to sedation. Truly, I think one of the most important things that we can do as intensivists is get patients liberated from invasive mechanical ventilation as soon as possible. And this certainly means a coordinated approach in terms of limiting sedation as much as possible. So rather than treating pain or agitation by simply ramping up sedating medications, again, the idea behind an analgesia first approach is to ensure that the pain is well treated before we turn to sedative agents. It's been shown that using this analgesia-based sedation approach has many advantages. We avoid, as I previously mentioned, a lot of the negative sequelae associated with over-sedating patients and improve sedation agitation scores. Obviously, with using analgesics, especially opioids, we need to watch for opioid-related adverse side effects, dysmotility, delirium, hypotension, and myoclonus. And along these lines, and in keeping similarly to the approach with sedation, although analgesia first is crucial, we should still use the lowest doses possible in terms of treating pain. And this is a lot of the motivation with using something like Dilaudid on a PRN or perhaps routine basis and avoiding infusions in which we may be over-treating with narcotics and perhaps increasing the risk of our patients to these ADRs. However, our approach to analgesia, it's important that patients undergo frequent reassessment. And this requires, in some units, protocol-based assessments, and we, as part of the guideline, made a conditional recommendation for this. But certainly, whether it's protocolized or not, bedside practitioners should entail frequent reassessments for pain and sedation needs and use a stepwise approach. We've talked about some of the negative adverse drug reactions related to narcotics, and I think many are familiar with these, and we experience these frequently in the intensive care unit. Things such as delirium, ileus from narcotics, respiratory depressing nature that limits our ability to liberate from mechanical ventilation. And because of this, there's probably an untapped market in terms of using adjuvants or other agents in conjunction with narcotics. And in fact, I've been doing a lot of work in this area with an anesthesia resident in Hamilton, where we've performed a systematic review meta-analysis looking at a number of these adjuvants and their potential role in the intensive care unit. This is a list of some of these adjuvants that have been investigated in randomized controlled trials. used often in conjunction with narcotics, with the goal of limiting opioid exposure and some of those negative effects. Probably one of the adjuvants with the best quality of evidence is acetaminophen. My sense is that this drug is still widely underused in intensive care patients. And I think certainly further work to be done, although would suggest that most of our patients on routine narcotics or narcotic infusions in the ICU would probably also benefit from routine acetaminophen administration. Depending on the location, you may have access to only oral, which is limited to those that are tolerating enteral medications. Some locations have access to the intravenous formulation of paracetamol as well. But I would definitely advocate for routine use of Tylenol in many of our critically ill patients, presuming there is no contraindications. Given the increasing role of ketamine as sedating agent in the critically ill, others have also investigated the utility of low-dose intravenous ketamine as an adjuvant for pain control. There actually is a small amount of data examining this, mostly in surgical patients. Although there's a potential for benefit seen from these trials, given the limitations, at least as part of the guideline effort, we ended up making a conditional recommendation based on very low quality of evidence for using low-dose ketamine as an adjunct to opioid therapy, specifically in those that are post-surgical. My sense is, in terms of ketamine, is that there's an increasing utility or role as using this as a sedating agent, perhaps in substitution to the more commonly used propofol. And at least some of this preliminary data suggests that there could be synergistic effects of the ketamine, both for sedation, but also for addressing pain needs. We've seen this also used in some medical patients around chronic pain in the pediatric world, as well as some of those adults with chronic pain requirements. So the role of ketamine in pain treatment is even outside of the critically ill setting is relatively well established. Another potentially underutilized adjuvant in critically ill patients would be neuropathic pain medications. There's probably more of a role for things like gabapentin, carbamazepine, and pregabalin in the critically ill patients that are requiring significant narcotics for pain control. Up until now, the data is mostly, again, similar to ketamine, limited to the postoperative population. And as such, our recommendation is specifically addressing those following cardiac surgery. But even in my own practice, I have expanded the use of these medications more widely. And certainly, I think, opportunity here for further research work over the coming years. Let's talk a little bit more about sedation. I mentioned earlier that one of the most important things that we can do as intensivists is liberate our patients from mechanical ventilation. No doubt this holds true for all etiologies of respiratory failure, viral pneumonia, bacterial pneumonia, or whatever it might be. In order to liberate our patients, this most often requires assessing for spontaneous breathing trials, and we know from data that patients are more likely to pass spontaneous breathing trials when they're also more awake. Makes sense. More somnolent patients not able to breathe, you try them on pressure support modes and their minute ventilation will drop. There's been a fair bit of investigation over the last little while, including a large New England Journal publication from a couple of months ago assessing light versus deep sedation in critically ill. I think we can all agree that using the least amount of sedation possible in mechanically ventilated patients is probably the best way forward. I know there are many centers that have moved away from even using sedation infusions as much as possible, trying their best to have their patients awake in bed able to interact with their environment, as I have no doubt that this helps in terms of decreasing the time of requiring mechanical support. As with everything, there are exceptions to these rules. Patients with severe ARDS, with compliance issues, hypoxia, and ongoing perhaps hypercarbia may require deeper sedation in terms of minimizing dysynchrony, limiting plateau pressures, perhaps even paralysis. But for the majority of patients, and a good question to ask yourself each day is, can I decrease sedation on this intensive care patient? And if I can't, why not? If you have a compelling reason why not, fine. If you do not have a compelling reason, every patient should attempt to wean sedation on a daily basis. In terms of how this weaning is done, a number of trials, the largest of which was called the SLEEP trial by Gita Mehta in Toronto, examined the rule for daily sedation interruptions. The idea being is that for each mechanically ventilated patient and less contraindication, all sedation infusions were turned off once per day. If the patient woke up nicely, calmly, an RSBI or spontaneous breathing trial were done, and it was looked to be whether the patient could be extubated. If not, the patient was resedated if needed. Although trials including the SLEEP trial, showed benefit of this approach, this actually led to, at times, more work for the nursing staff, as they had to rebolus patients that did not tolerate their daily sedation interruption. The alternative approach is more in keeping with what I have just discussed, and entails aggressive weaning of sedation on a daily basis in all mechanically ventilated patients. I think either approach is reasonable, the daily sedation interruption or the aggressive weaning approach. Whichever, and this is reflected in our recommendation as well. Whichever is chosen, it's important that at least one of them is done rather than leaving patients on high levels of sedation each day. There's no doubt that in terms of care, it is easier to leave patients deeply sedated. But again, I can't stress enough the importance of coordinating spontaneous awakening trials with spontaneous breathing trials in terms of maximizing liberation. When we are talking about sedation, which agents are optimal? For those that have been more familiar in working in intensive care units 10, 15 years ago, midazolam and benzodiazepines were our agent of choice. This has evolved over the last few years with a stronger preference for using short-acting agents like propofol and dexmedetomidine. This is results from a meta-analysis published in Critical Care Medicine in 2013, comparing benzodiazepine sedation infusions versus non-benzodiazepine sedation infusions. You can see that with non-benzodiazepines, patients had shorter lengths of stay, shorter durations of mechanical ventilation, with no effect on mortality or delirium rates. The walk away from this is, again, use the least amount of sedation possible, and if you are going to use sedation infusions, in most situations, using non-benzodiazepine regimes is optimal to benzos. Most commonly, this is propofol. There's increasing use of dexmedetomidine, although given the cost considerations and the uncertain efficacy compared to other options, this may be reserved for select situations, depending on unit availability. It does seem that patients that are more elderly, as well as those withdrawing from intoxication, may be most suitable for a trial of dexmedetomidine if availability allows. The results of this meta-analysis and what I just discussed was epitomized in our guideline recommendations, suggesting either propofol or dexmedetomidine over benzos if sedation is to be used. Next, let's briefly discuss delirium. A number of medications have been investigated for their role for preventing delirium, in particularly those patients that are high risk. We all understand the significant impact of delirium, both on ICU length of stay and risk for complications, and recognize the need to prevent it. Certain drugs, including typical, atypical antipsychotics, dexmedetomidine, statins, ketamine, even newer agents being investigated like melatonin, Unfortunately, none have shown efficacy in terms of preventing delirium. Delirium prevention, as you'll see with treatment, often unfortunately really comes down to non-pharmacologic interventions. Routine stuff like preserving sleep structure, limiting noise and light in terms of earplugs and eye protectors, orienting to time and day, ensuring hearing aids and visual aids are applied, limiting polypharmacy. This is really the best that we can do still in terms of limiting delirium, given that none of these drugs have been found to be efficacious. A number of these same drugs have been examined for the treatment of delirium and similarly have not shown benefits. There was just published in the last year or two large randomized controlled trials looking at both typical and atypical antipsychotics. And although previously used to treat or decrease duration of delirium, neither was found to do benefit either of those outcomes. That being said, I do believe there is still a role for either atypical or typical antipsychotics in delirium, specifically in the situation where patients are acting unsafe to themselves or healthcare practitioners. So I think this is the one place where we may still consider antipsychotics. If a patient is causing harm to themselves or others, they may still be used. IM or subcut or IV Haldol is a good option, couple milligrams every 4 or 6 hours. But again, we do not routinely use any medication in the terms of the treatment of delirium. This is really supportive management and treating the underlying cause. We did find one small randomized controlled trial in 71 patients looking at dexmedetomidine and its ability to treat delirium. Did show increase in ventilator-free hours in those that were randomized to dexmedetomidine, although there were limitations in the study design that prevented widespread conclusions. As such, we did make a recommendation that dexmedetomidine may be reasonable in treating delirium, specifically in older adults in which this smaller study was done, and when agitation is precluding weaning and extubation. This is predominantly how we use dexmedetomidine in my own unit. If we've used other sedation drugs like propofol and still run into issues that are severely limiting our ability to extubate the patient safely, mostly around agitation, is that we will use dexmedetomidine as a second line rather than first line, and with a short trial, perhaps over a couple of days, to see if it might help facilitate liberation. Again, I think the two subgroups of patients that this is most reasonable in are specifically the older or elderly population and those that are suffering from withdrawal from drugs or alcohol. The ABCDEF bundle highlights a lot of these concepts that we've talked about over the last 15 or 20 minutes. Assess, prevent, and manage pain. Do this before sedation. Coordinate spontaneous awakening trials and spontaneous breathing trials. I find in my own units sometimes variable whether spontaneous breathing trials are performed by the respiratory therapist each morning, but certainly they should be on a regular basis in patients that are on support modes for breathing. And not only just once a day, but perhaps there's opportunity for reassessment later in the day, and further actually randomized controlled trials are assessing this at the time where, we check for spontaneous breathing in the morning, the team rounds, diureses the patient, decreases sedation, does things to improve the patient's status. Likely in these patients that we think are getting close to a trial of extubation, perhaps reassessing around lunchtime or early afternoon to see whether they may pass a spontaneous breathing trial. Again, the crucial part of this is coordinating spontaneous awakening, is that if we're maximizing our possibility that the patient's going to be successfully extubated, coordinating a decrease in sedation or turning off of sedation around the time of a spontaneous breathing trial is probably optimal. This is also encapsulated in the CDC's effort called Wake Up and Breathe, which has similar goals of combining these two trials. Be careful in your choice of analgesia and sedation. Try and limit both as much as possible. If you are to use sedation, probably non-benzodiazepine regimes are most important. Assess, prevent, manage delirium. Key here being non-pharmacologic management for almost all aspects. And again, I think we minimize the importance of orienting features, sleep wake cycle, so many things that we could do in terms of limiting investigations overnight, limiting sound and noise, limiting vital signs overnight in more stable patients to ensure that we really do preserve nighttime sleep even in our critically ill. Early mobility and exercise I did not discuss much in this presentation, but also crucial concepts. You talk with most ICU physiotherapists, and in their eyes, rehabilitation starts at the moment that the patient's intubated. We've been looking at novel applications of in-bed cycling for mechanically ventilated patients, but certainly rehabilitation must start immediately, even while patients are critically ill. And family engagement, empowerment, more challenging in times of pandemic with limited visiting hours, but always looking at unique ways to interact with family, certainly phone calls, perhaps Skype video calls, all really, really important outside of pandemic times, looking at including families in daily rounds, increasing transparency, and bottom line, showing them how much you care for their family member and are trying to do what's best for them. Again, I think this is a nice summary of the main concepts around pain, agitation, delirium guidelines. That's all in terms of audio to accompany this PowerPoint. Appreciate you listening and look forward to working on the front lines with those that have volunteered to help in this time of need. And wish you all to be safe and keep well. Thank you.